Bismillah ar-Rahman ar-Rahim. Uh, Now I'm going to talk in the next maybe 45 minutes about the hypertension. In this lecture, we're going to talk about shortly about the epidemiology of hypertension, the classification and definition of hypertension, and how to correctly manage the blood pressure in order to diagnose high blood pressure. What is the complications of untreated high blood pressure or hypertension, and the non-pharmacological and pharmacological treatments or optional treatments for hypertension, and ending with an issue that's related to the field of dentistry in case you are managing patients in the dental department having a high blood pressure. So it is a highly prevalent disease actually, as the global prevalence of hypertension is high, and among the non-pregnant adult, treatment of hypertension is the most common reason for office visit and for the use of the chronic prescription medications. Not only is the most highly prevalent, it is also the most highly prevalent risk factor for cardiovascular disease like stroke, ischemic heart disease. In addition, roughly one half of all hypertensive individuals do not have adequate blood pressure control. It has been told that it is a rule of 50. For example, it is about 50% of people who are more than 50 years old having high blood pressure, and half of those patients, 50% of them, they do not aware of having hypertension. And for those who are aware to have a hypertension, half of them, 50% of them, only on treatment. And for those on treatment, only 50% of them having a controlled blood pressure while on treatment. So what is the ideal way, very important for measurement of blood pressure? We have three different strategies for management of for measurement of blood pressure. The office-based blood pressure measurements. It is the real-time measurement of blood pressure that you can do in your clinic using a sphygmomanometer or even a validated automated device. And also we have the ambulatory blood pressure monitoring that is sometimes needed in the home setting as indicated by the doctor in order to check for a blood pressure variability. For example, sometimes when we have a difficulty in that pressure, high blood pressure. And finally, we have a home blood pressure monitoring, and maybe many of you having a home blood pressure monitoring have a device that can be used at home for measurement of blood pressure, whether the sphygmomanometer or the automated device. The office-based blood pressure measurement. It's easy to measure blood pressure for your patient, even in your dental department. For example, before you are going further in your dental management, you may need to measure the blood pressure for your patient, especially if you think or suspect that this patient having hypertension, or he is hypertensive on multiple antihypertensive medications. You may think I have to measure the blood pressure before I go further with the dental management. While it is easy, but there are important steps and important tips that you have to in order to get the ideal and the correct blood pressure readings. Otherwise, the blood pressure measurement will be incorrectly recorded. So the step one, you have to properly prepare your patient. Have the patient relax and sitting in a chair, and the foot on the floor and the back is supported. And this should be done for 5 minutes. For example, you cannot measure the blood pressure while patient recently walking and sitting on a chair, because this will result in a high reading of blood pressure. كلية طب الأسنان المرحلة الرابعة. يا ريت تطفي المايك مالتك لأن جاي أقدم محاضرة. طفي المايك مالتك. طفي المايك. For 5 minutes. And the patient should avoid caffeine, exercise, smoking, and even eating sometimes 30 minutes before the measurement. Ensure that the bladder is emptied. This simply by asking the patient, do you have a desire for urination, or have you recently emptied your bladder? And during the measurement of blood pressure, neither the patient nor you should talk, especially talking to the same patient. And remove the clothing, all the clothing covering the location of the cuff placement. خل افتح الكاميرا لان احتاج مرات اشتغل لكم شغلات بايدي. تمام. تمام. So you have to remove the clothing at the side for the placement of the cuff. The step 2 for the proper technique of blood pressure measurement. The first thing you have to use the ideal and validated device. A sphygmomanometer considered as a validated device, and some of the automated أجهزة إلكترونية also considered a validated device for blood pressure measurement. Support the patient arm by resting in this. So for in this position, the arm should be placed like this, or on the hand on the chair, should be supported, not lagging like this, because this will also result in a false reading of blood pressure. Position the middle of the cuff on the patient upper arm. So the cuff should be placed in the middle of the cuff of the arm like this, at the level of the heart, especially at the level of the right atrium of the heart, and use the correct cuff size. The correct cuff size, it is about 2/3 or 80% of the distance between this and this, between the elbow joint and the shoulder, should be 80%. And either the stethoscope, the diaphragm of the stethoscope, or the bell, you can use it for the auscultatory reading, because we can measure the blood pressure by two-way, by the auscultatory method and also by palpatory method. Take the proper measurements needed for diagnosis and treatment. So at the first visit, record blood pressure on both arms, on the right and left arm, and you have to rely on the highest reading, whether it is on the right or the left. And separate repeated measure, you have to measure the blood pressure twice. The two measures separated by 1 or 2 minutes. And for auscultatory determination, you have to start by palpatory method. For example, you are fitting the cuff here and elevating the sphygmomanometer pressure above a certain degree of blood pressure. Now you are releasing the air in order for descending, in order to check for blood pressure. At this time, you have to check blood pressure by palpatory method. This by putting your finger on the radial artery, checking for pulsation. The moment that the pulse appears in your finger, even if it is weak, it represents the systolic blood pressure. By this maneuver, you are checking only the systolic blood pressure. نعم.
بلا زحمة عليك دكتور، بس شوية نزل الكاميرا لأن ما جاي يبين، بس يعني تشيس مالتك ما جاي يبين حد الشولدر. ايوه
اوكي والله دقيقة. هسه على كل مبين واضح؟
هسه تو دكتور عاشيدك دكتور، ممنون.
تمام. Okay. So in this way, you will elevate the systolic blood pressure to a certain degree, and you will put your fingers on the radial artery, and you will release the pressure, waiting for the appearance of the radial pulse. So at the moment that the pulse appears, that represents the systolic blood pressure. This measurement of the systolic blood pressure by palpatory method. That is why it is called by palpation. So you'll have a palpatory measured systolic blood pressure. Then you have to elevate the pressure again, and you'll put your stethoscope here. You will elevate the pressure above the systolic blood pressure that is measured by palpatory method. For example, if you detect a systolic blood pressure that is 150 millimeter mercury by palpatory method, when you're going to use the auscultatory method, you will elevate the blood pressure, for example, 160 or 170. And now we're going to release the pressure. And by hearing this, by the stethoscope, the first sound that appeared called the Korotkov sound. It's maybe pulsatory sound or noisy sound. The first sound that appeared, it is the systolic pressure. That's it. And you will continue releasing the pressure by 2 millimeter mercury every second, so that is slowly and carefully till the disappearance of the Korotkov sound. The moment that the Korotkov sound disappears, we present the diastolic blood pressure. This is the ideal and the correct way for the measurement of blood pressure. So you will record a systolic blood pressure reading and diastolic blood pressure reading. If you use the auscultatory technique, you will record the systolic and diastolic, as I said, but in the palpatory method, you will record only the systolic blood pressure. Note the time of most recent blood pressure medication taken before measurement. You have also to ensure that the patient is taking his medication if he has a diagnosis of hypertension. Use the average of two readings. The two readings that obtained, you have to take the average of them, and on 2 occasions in order to diagnose the blood pressure. Finally, you have to write down the reading of the systolic and diastolic blood pressure, and you can tell your patient verbally that your blood pressure, for example, is 135 over 80 millimeter mercury, and it is better to write it down on a paper to give it to the patient, and especially if you write down the blood pressure and the time of the measurement of blood pressure. This is the office-based and the commonly used way of measurement of blood pressure in many offices, in my office, in your office. All of you can measure the blood pressure in this way, but it may be more easy if you have a well-validated automated device. There are many automated devices available out there, but should be validated. Definition of hypertension based on the office-based blood pressure. The normal blood pressure is systolic below 120 and diastolic below 80 millimeter mercury. Elevated blood pressure, it is the systolic blood pressure between 120 to 129 and diastole less than 80 millimeter mercury. And so the hypertension stage 1. The hypertension stage 1 starts when the systolic blood pressure between 130 to 139. This is considered as stage 1 hypertension, or the diastole that is more than 80 to 89 millimeter mercury. A higher blood pressure, for example, if it is at least 140 in the systole or at least 90 in the diastole, is a definition of a stage 2 hypertension. Also, sometimes we have what is called isolated, either systolic blood pressure or isolated diastolic blood pressure. The isolated systolic blood pressure is a systolic hypertension, a systole that is more than or equal to 130, while the diastole is less than 80. And isolated diastolic blood pressure is a systolic blood pressure that is below 130, while diastole is equal or more than 80. Whatever the blood pressure is systolic or diastolic, in any way, this considered as hypertension and should be treated and should be evaluated. Also, we have what is called the ambulatory blood pressure monitoring. This is a device that kept on the right arm of the patient, or the left arm of the patient, in order to measure the blood pressure serially. To measure the blood pressure serially at home, and this usually needed if you have a question about the diagnosis of hypertension. whether there is a real hypertension or not. For example, in patient having what is called the white coat hypertension, or if you suspect a masked hypertension. In the next slide, I will tell you what is the and and okay. At 24 hours, because it is 24-hour readings of measure of blood pressure, a mean of systole that is more than or equal to 125 systole or equal or more than 75 diastole is definition of hypertension. You can see here the cutoffs for the definition of hypertension differ from the cutoff of the office readings, because simply we have to consider that in a person who's at home at rest should have a lower blood pressure. And as you see also, there's a variability, and this variability of the daytime blood pressure and nighttime blood pressure, especially the sleep time, is different. The nighttime readings of blood pressure is usually low, and this is a normal phenomenon, because if you have an increase even at normal levels, but increase in the nighttime blood pressure, this should be taken seriously and should be considered hypertension. And you can see the daytime awake mean readings of the ambulatory blood pressure. The hypertension diagnosed when the blood pressure equal or more than 130 or more than 80 in case of diastole, while the sleeping person, while he is sleeping, a systolic blood pressure that is equal or more than 110 or equal or more than 65 millimeter mercury in case of diastole is a definition of hypertension in the ambulatory setting. For you as a dentist, you will usually rely mainly on the office-based blood pressure measurement. What is called white coat hypertension and the masked hypertension? The white coat hypertension, white coat هي الصدرية اللي انتوا تلبسوها. Some patient may have a consistently elevated office reading of blood pressure, but they don't have an end organ damage or complication of hypertension, and their blood pressure measurement at home are completely normal. So they have hypertension only when you are when this patient is facing you. He's afraid from you. So this stress called a white coat hypertension. It is not considered a hypertension that should be treated. And this is one of the reasons you sometimes need to refer the patient for ambulatory blood pressure recording in order to confirm whether this patient having a real hypertension or just a white coat hypertension. The masked hypertension, when there is a consistently elevated out of office measurement. The blood pressure is high in the out office measurement, but he does not meet the criteria of hypertension based on your readings. So in your office, the blood pressure is okay, but the readings that was measured at home is high. So this is a masked hypertension. Masked hypertension should be considered as hypertension as treated and also treated as hypertension. Classification of hypertension. Simply the hypertension, we have two classifications. Classification of hypertension. We have primary hypertension, the essential hypertension. It is the hypertension that is with unknown cause, which is the commonest hypertension that you will see in clinical practice. When you face a patient, tell you, I have hypertension. The secondary hypertension is a hypertension that is happened or developed secondary to underlying disease. So, what is the primary hypertension? The blood pressure is the measures that is dependent on the cardiac output and the systemic vascular resistance. So, a disease or something or any abnormality that can affect either the heart, such as an increase in the cardiac output, or that result in increase in the systemic vascular resistance, will result in elevation of the blood pressure. And keep in mind the underlying cause for primary hypertension or the physiology or the pathophysiology is still not proven completely, because the blood pressure reacts to changes in the environment, and this is very important to maintain the organ perfusion over a wide variety of conditions. But there are many primary factors that determine the blood pressure. such as the sympathetic nervous system. That is why in our locality nowadays we have a common and frequent diagnosis of hypertension even in a younger age group due to increasing the sympathetic nervous tone. The sympathetic nervous tone due to the stress of life, especially in the presence of many many disaster thing nowadays in our country. The renin, angiotensin, aldosterone system, the plasma volume, all of these can affect the blood pressure. But at the same time, there are risk factors that increasing the risk for development of the primary or secondary hypertension. These risk factors you have to consider it in mind in order to know whether this patient it is worthy to measure the blood pressure correctly. Even mind you have to measure the blood pressure for your patient before you are going to proceed in the dental management, especially in an old patient. For example, for any patient who is older than 40 years old, you have to measure the blood pressure. Aging by itself is the strongest risk factor for development of hypertension. Obesity, a family history of hypertension, race. The black people have a tendency to have a higher blood pressure and also have a tendency to have a resistant hypertension that is difficult to control with treatment. A high sodium diet, high salty diet, for example, more than 3 grams per day. Excessive alcohol consumption, that is above the moderate consumption of alcohol, and physical inactivity. These are considered risk factors that increase the risk for development of hypertension. What about secondary hypertension? Secondary hypertension is the blood pressure that is high due to the presence of underlying cause. And if you are going to treat this underlying cause, you will treat hypertension. These are the list of causes that is associated with secondary hypertension. The drugs. These drugs commonly used in clinical practice, oral contraceptive pills. The especially the steroid-containing contraceptive pills, is a cause of increased blood pressure. Non-steroid anti-inflammatory drugs, especially the strongest one like the diclofenac sodium, for example, the indomethacin, these associated with increased blood pressure. Many antidepressants, corticoids like dexamethasone, hydrocortisone, mineralic corticoids like fludrocortisone, decongestant that is used for rhinitis, especially that containing phenylephrine. Some weight-losing medication, especially that containing the phenylephrine or phentermine, can cause increased blood pressure. Sodium-containing antacid, erythropoietin, and illicit drug. Illicit drug, these are non-prescription medication that's used by many patients, many persons abused, like amphetamine or NDMA اللي هو الميثيل بالكريستال associated with a high blood pressure. So you have to think of this medication if you have a hypertension in a young age group, or if you have a hypertension that is difficult to control despite the patient on medication, because these are causing secondary hypertension and cause me sometimes resistant hypertension. Primary aldosteronism is a cause of secondary hypertension. It is a disease when the adrenal glands secrete more aldosterone than usual, either due to tumor or by genetic causes. It will result in hypertension. Aldosterone will keep absorption the sodium and fluid, resulting in hypertension. Other endocrine disorders like hyperthyroidism, hyperparathyroidism may be associated with hypertension. Primary kidney disease, obstructive sleep apnea, renovascular disease. Renovascular disease, when there is a stenosis in the renal artery, there will be hypertension that is resistant and difficult to control and also cause secondary hypertension. Pheochromocytoma, it is a disease, a result of adrenal tumor that resulted from the adrenal medulla that secrete the catecholamine, adrenaline and noradrenaline. So of course it will result in a severe hypertension. Cushing syndrome, when there is a hypercortisolism, I said the use of glucocorticoid associated with high blood pressure. Cushing syndrome, here is the endogenous excess of cortisol from the adrenal gland, will result also in hypertension, and finally coarctation aorta causing hypertension by a similar mechanism of renal valve disease. These are the list of causes of secondary hypertension. Classification complications of hypertension. Untreated hypertension will result in these complications: left ventricular hypertrophy, heart failure, whether this heart failure is diastolic or systolic heart failure. Ischemic stroke, it is a leading cause and the most important risk factor for stroke, even importantly the ischemic stroke. And also especially the hypertension can result in intracerebral hemorrhage, ischemic heart disease, and chronic kidney disease. But the good news that correct and accurate treatment of blood pressure, especially if the patient kept compliant with his medication, can prevent all these complications. If you have a patient having a hypertension, the evaluation should include history, examination, and investigations. This evaluation by history, examination, investigation, looking for these things: the extent of target organ damage. The target organ damage could be the eye, resulting in hypertensive retinopathy, the kidneys, resulting in kidney disease, the heart will result in left ventricular hypertrophy, ischemic heart disease, etc. And this evaluated by history taking, by clinical examination, and sometimes by investigations. The presence of established cardiovascular or kidney disease, and the presence or absence of other cardiovascular risk factor. This patient having hypertension, simply just ask the patient, you have only hypertension or you have another conditions like diabetes, dyslipidemia? Are you currently on treatment for heart, for ischemic heart disease, or stroke? Because the presence of these other risk factors will result in a complexity of this risk factor that increase the risk for cardiovascular disease. Lifestyle factor that could potentially contribute to hypertension. For example, as we said, alcohol consumption, smoking as a risk factor for cardiovascular disease, physical inactivity, obesity, and drugs. That the list of drugs that can cause secondary hypertension. You have to ask about them. Even if the patient is normally he has hypertension, you have to ask about them because it will result in resistance to the action of these medications. The treatment of hypertension. We have two strategies of treatment. The first strategy that should be done in all patients, it is called the non-pharmacological approach for management of hypertension. He is just before you are starting treatment for your patients. First, simply, if your patient is obese or overweight, encourage your patient to lose weight. The best goal is to have an ideal body weight, but even sometimes it's very difficult. But any kg weight loss, it will affect the blood pressure management in a positive way. So encourage your patient to lose weight. Eat a healthy diet. It's very simple. Consume a diet that is rich in fruit, vegetables, whole grains, and reduce the amount of fat, especially the saturated fat and the trans fat. This importantly because it will result in better control of blood pressure. Reduce the intake of dietary sodium, and the optimal goal is less than 1500 milligram per day. And this roughly, just you can tell your patient just like this. What I'm used to do to my patient with hypertension. I told them that everything you are eating already containing a sodium, already containing a salt. So it is not needed to add a salt to your diet. But if you insist or if you need to add a dietary sodium to your 24-hour diet, the total amount of salt that should be added should be less than this. This is a half teaspoon of salt. This is the total amount that a patient with hypertension should be on. Enhance the intake of dietary potassium, because many conditions of hypertension, especially if the patient on treatment of hypertension, may have a low potassium. Consumption of diet rich in potassium, especially fruits, can affect the management of blood pressure positively. Enhance the physical activity. Simply walk. Enhance the walk, but not every walking. The brisk walking is the best. and with an average of 90 to 150 minutes per week. You can tell the patient to spread these minutes over 3 days, over 5 days of a week, whatever. This enhances the control of blood pressure. Moderation of alcohol consumption, reduce the total amount of alcohol, especially for those who have excessive intake of alcohol. And this equivalent to 2 or less drink of alcohol daily or less than 1 drink daily. The pharmacological approach for treatment. The first question, before we are going to prescribe an antihypertensive medication to our patient, we have to ask ourselves this question, that is it worthy to treat this patient with antihypertensive medication, because not every patient should be treated. That is why we have a target for initiation of antihypertensive medication prescription. In case of the out of office daytime blood pressure that is equal or more than 135 or equal or more than 85 diastole, or on an average office blood pressure reading, or average office that is equal or more than 140 systole or equal or more than 90 diastole. At this moment, you have to initiate the antihypertensive medication, and you cannot rely on the non-pharmacological approach only. So at this moment, we have to address the non-pharmacological approach plus administration of antihypertensive medications. These are the commonest classes, not the only classes. We have many classes. I give you the 4 important classes that most commonly prescribed, what is called the first lines of treatment of hypertension. And I gave you 3 examples of each. We have the thiazide type diuretics like hydrochlorothiazide, indapamide, chlorthalidone, the long-acting calcium channel blockers, amlodipine, the most commonly prescribed of them. We have also nifedipine, that's commonly used in pregnancy, and diltiazem. Angiotensin converting enzyme inhibitor. These are the once daily treatment. I gave you the examples of once daily drugs like lisinopril, perindopril, and ramipril. And finally, we have angiotensin receptor blockers, have a similar action to these medications, and for this reason, we cannot and never combine the angiotensin converting enzyme inhibitor with angiotensin receptor blocker. Either you choose that or choose that, plus the addition of that and that. The combination of these 2 medications is totally contraindicated. We have the valsartan here, the losartan, and candesartan. One of the important side effects of the antihypertensive medication simply the hypotension, simply because these are antihypertensive medications, and sometimes a postural drop. The diuretics not only associated with postural hypertension, also associated with electrolyte disturbances, and commonly associated with low sodium with hydrochlorothiazide that is maybe hazardous, especially in the elderly patients, for those patients older than 65 years old. The angiotensin converting enzyme inhibitor, a common side effect associated with this medication is the irritative dry cough. So the patient sometimes feels just like this, feel something here with the use of these medications. If a patient has such a side effect, we usually stop this medication and shift to angiotensin receptor blocker because it carries a less side effect. And of course, why this happened with the use of these medications, due to the inhibition of the kinase that's responsible for the degradation of the allergens, that's allergic mediators that are present here in the upper airway. Blood pressure goals. You started treatment for your patient, whether the pharmacological approach or the non-pharmacological approach. The goal is to have a systolic blood pressure that is less than 130 and the diastole less than 180. This is using the out-of-office measurement, the reading that the patient measure it and give it to you. This is an out-of-office measurement. And the other goal is 135 systole or 85 diastole in the out-office setting, or less than 140 systole or less than 90 diastole office measurement. But this secondary goal indicated if the patient having a labile blood pressure or postural hypertension, because if you are going to intensify treatment for antihypertensive medication will result in more hypertension attack. Okay, and patient with side effect of multiple antihypertensive medication and elderly patients that are 75 years or older. In those patient population, you need a higher goal, because avoiding this a more stringent goal in those patients because it may be harmful for them due to the risk of hypertension. And finally, I will end with this slide that represents the dental management of patients who having cardiovascular risk factor. It is a similar slide that I previously presented to you in a lecture before the mid-year examinations about diabetes. Postponed or elective procedure. If you have a patient presented to you for an elective procedure, you have to postpone all elective procedure if the office measurement of blood pressure at the time of the procedure is equal or more than 180 over 110. Simply you have to postpone it, refer it for a blood pressure measurement, even if the patient is on antihypertensive medications. So one of the indications to postpone this elective procedure is the severe hypertension. Elderly patient also you have to postpone elective procedure unless you do an evaluation for this patient. Post-myocardial infarction or unstable angina, myocardial infarction, جلطة قلبية, unstable angina, especially if the patient recently discharged from the hospital for such a conditions. In patient with diabetes, if the patient have a fasting blood glucose less than 70 or more than 200, while the patient here in your dental clinic, you have to check also his blood glucose. If it is less than 70 or more than 200, you have to postpone the elective procedure because simply it is elective. Symptomatic stable angina. If the angina is symptomatic, stable, but it's symptomatic, for example, the patient will develop chest pain whenever he walks, you have to postpone elective procedure unless something dangerous and something disastrous will happen while the patient lying on your chair. But you have to consult the physician or consult the endocrinologist about the blood glucose before doing this elective procedure, and he will do the correct management before you proceed in your surgery. But you can provide an emergency care. Emergency care, if you are in a way you have to do an emergency procedure for your patient despite having such any one of these factors, you have to prepare yourself that you have to do ECG monitoring, blood pressure monitoring, and heart rate monitoring, because the patient may develop something disastrous like may develop more severe hypertension, more severe hypoglycemia, and stroke due to hypoglycemic attack or hypoglycemic shock, or may develop heart attack while he is lying on your chair. And so this is the final slide of this lecture, and thank you. If you have any questions, I'm ready to receive this question from you. ما عندكم سؤال؟